Hello, my name is Jennifer Stransko, and I'm the Physician Engagement Associate for MAVEN Project. Thank you all for joining us today and our friends at Community Health Center of Cape Cod for hosting today's session, Hypertension Update 2024 with Dr. Charles Schulman. Dr. Schulman was an assistant clinical professor of medicine at Harvard Medical School from 1988 until 2016. He is currently a corresponding member of the faculty of Harvard Medical School and a senior physician at the Beth Israel Deaconess Medical Center in Boston. In addition, he has been practicing non-invasive cardiology since 1970. Dr. Schulman's scientific articles and abstracts have appeared in the New England Journal of Medicine, Circulation, the American Journal of Cardiology, and the British Heart Journal. His research interests include the treatment of hypertension, congestive heart failure, and hyperlipidemia. And Dr. Schulman, it's all yours.
Okay, well, thank you very much, Jennifer, and good morning, everybody. In a way, I wish I were on the Cape, but no matter, I'm in Newton. So today we'll talk about hypertension and review some of the key concepts and details that practitioners should have. I have no disclosures, nor does anybody else involved in this activity, and MAVEN designates this for an hour of Category 1 credit. So starting out with where we were, so to speak, I show you this information about President Franklin Delano Roosevelt and some of his blood pressure numbers from 1937 to 1944 or 45. He was noted to have systolic hypertension at the age of 55 at the time of his second inauguration. 4 years later, his blood pressure was 188 over 104. 2 years after that, it was 210 to 260 over 112 to 150. And in 1944, it was 240 over 130 and 260 over 150, and he had heart failure. Now, of course, at the time, there was no treatment for hypertension, and the treatment for heart failure was digitalis, which was successful to an extent. And then, of course, on April 13th, 1945, he suffered a cerebral hemorrhage, which the doctors at the time thought it, quote, came out of a clear sky. There was no indication of imminent danger. Things have certainly changed since then. We have many more tools at our disposal in order to try to prevent this sort of thing. So the learning activity, the learning objectives for this activity are to know the proper technique for measuring blood pressure, to know blood pressure goals, and to implement the strategy for initial and subsequent non-pharmacologic and pharmacologic management, and when to look for secondary drivers. Hypertension is a pervasive problem worldwide. It's estimated that 122 million people in the United States have blood pressures over 130 over 80. Which, as you'll see, is the gold standard. 3 out of 4 people, 3 out of 4 hypertensive adults do not have controlled hypertension, that is, have uncontrolled hypertension. It's a little bit less in elderly patients, but still it's in the 70 to 75% range. In 2021, 124,500 deaths in the United States listed hypertension as a primary cause, and obviously the costs are enormous. The prevalence of hypertension rises with age. These are the latest statistics published in the American Heart Association Heart and Stroke Statistics in this year, and show that the incidence of hypertension rises as we age, so that over the age of 65, 72 to 75% of people have hypertension, and over the age of 75, it's over 80%. So it's an extremely, extremely common problem, and we all have to deal with it. This is not new data. This is 20-year-old data on blood pressure and coronary heart disease death. A meta-analysis of 61 studies of over 1 million adults, correlating age and blood pressure and risk of ischemic heart disease mortality. And as you can see, there are a series of curves at different ages. So the consequences of hypertension are also increased with age, and they also increase with increasing blood pressure. This is for men, this is for women, and the risk, it turns out the risk of cardiovascular death doubles for every 20 over 10 millimeters of mercury increase over 115 over 75, as low as that. More recent data shows that with increasing systolic and diastolic blood pressure, cardiac events are increased. So with the normal blood pressure, 120 over 80 is the reference, elevated blood pressure and hypertension have increased risk of mortality, stroke, coronary heart disease, myocardial infarction. Now, I'm going to show you two trials that are relevant here. There have been many hypertension trials over the years, but this one was really a game changer. A landmark study called the SPRINT trial, run by the NIH to try to help answer the question, what's the effect of lower blood pressure target goals? So they randomized over 9,000 patients. The standard treatment at the time was a goal systolic pressure of under 140, they describe an intensive treatment group with a goal systolic blood pressure of under 120. A third of them were females. 28% are over the age of 75, and 30% of them were African Americans. The primary outcome was a composite of myocardial infarction, acute coronary syndrome, stroke, heart failure, or death from cardiovascular disease. These are the results: a 25% reduction in the primary outcome and in all-cause mortality. That's important, all-cause mortality. The results were even better in those patients over the age of 75, 34% reduction, highly statistically significant in both cases. As with any other treatment, there is some, quote, cost, end quote, side effects. There was more hypotension and injurious falls in the over 75 age group, but none of the other side effects were statistically significant. Now, this is a newer trial. This is a trial that was done in China and confirmed those results in older patients. 8,500 subjects between the ages of 60 to 80 a standard randomized to standard treatment of systolic blood pressures of 130, 6 over 150, and an intensive treatment group with a goal of 110 to 130, and again a 26% relative risk reduction, statistically significant. So this confirms the sprint results. One thing I found interesting in putting this talk together is that blood pressure lowering can lower the risk of new onset type 2 diabetes. There's a recent article from the Blood Pressure Lowering Treatment Trialists collaboration, and found that treatment of blood pressure resulted in a lower risk of new onset type 2 diabetes, especially for ACE inhibitors versus placebo, ARBs versus placebo, but not for beta blockers. When your patient comes in, there are 3 questions to ask before you measure their blood pressure. Were you rushing to get here or physically active right before this appointment? Did you smoke a cigarette right before or have 2 cups of coffee? Have you been taking your medicine? That's going to turn out to be a key issue. And what's your diet and physical activity regimen like? Okay, so turning to the assessment of blood pressure, of course, we want to know how to do it properly. And here's a cartoon figure with a number of common mistakes that people make when taking blood pressure. Can you find them? Put something in the chat. Okay. Yes, you guys are good. You guys are good. He needs to go to the bathroom. So okay. His blood pressure is being taken over his clothes. His legs are crossed. His back is not supported. And he's drinking a cup of coffee and talking. This, of course, is the right way to do it. So don't talk. Don't have cigarettes. Have your arm have the blood pressure cuff at roughly heart height on bare skin. Legs back supported, legs uncrossed is the right way to do it. Now, in years past, there was something called the JNC, the Joint National Committee for the Evaluation of Prevention, Detection, and Evaluation and Management of High Blood Pressure. JNC number 7, so there were 6 previous ones. JNC number 7 was 2003. After that, there was an attempt at JNC 8, but it was never really published, and this Joint National Committee basically went out of business. And their tasks were taken over by the American College of Cardiology and the American Heart Association. So ACC and AHA have been publishing guidelines for all sorts of cardiovascular conditions, and their update of the hypertension guidelines dates from 2017, 6 years ago, or 7 years ago now. Okay. The definition of normal blood pressure has always been less than 120 over 80. In the older guidelines, from 120 to 140 was called pre-hypertension. But in the newest guidelines, 120 to 130 is called elevated blood pressure, and stage 1 hypertension begins at 130 over 80. Stage 2, of course, is higher than that. So the definition of high blood pressure is a blood pressure greater than or equal to 130 over 80. Now, one of the important considerations in treating blood pressure is salt intake. High dietary sodium intake raises blood pressure, and the mean sodium intake in the United States, when it's been measured, ranges between 2,300 and 4,700 milligrams per day, which is 4,700 milligrams is a lot of salt. Limiting salt intake lowers blood pressure, reduces extracellular fluid volume. Okay, and has been shown to reduce blood pressure, depending on whether you have pre-hypertension, hypertension, or resistant hypertension. And in any of these conditions, lowering the sodium content of the diet to 1,800 to 2,300 milligrams per day becomes important. Now, of course, you need to pay attention to dietary intake, and so we have some quiz questions. Okay, how's your sodium knowledge? Which one has more sodium, the Hebrew National Beef Frank or 11.5 ounces of V8 vegetable juice? Put your answers in the chat. There we go. Okay. Well, we have 2 votes for 2 votes for V8. Well, let's see, 1, 2, 3 votes, 4 votes for V8, and 1 vote for Beef Frank. Okay, and the answer is the V8. The Beef Frank has 480 milligrams of sodium. The vegetable juice has 920 milligrams of sodium. Which has more sodium? A Panera Bread Southwest Caesar salad with chicken, or a slice of Domino's pizza, pepperoni pizza? Okay, we have a couple. Oh, mixed. Mixed results, and the answer is the Panera Bread Southwest Caesar salad. The salad has 1,000 milligrams of sodium. It beats the pizza, which only has 830 milligrams of sodium, but those are considerable amounts of sodium. If you consider that we should ask people to restrict their diets to 2,000 milligrams in a day, you have the salad you eat, and you had half of the day's, half of the day's allotment. But even with the pizza, you're over 35% of it. Okay, one more. Which has more sodium? A Chipotle burrito with rice, beans, plant-based protein, salsa, guacamole, cheese, and sour cream, or an Olive Garden chicken marsala fettuccine entree? Again, mixed result. And the answer is the burrito. Look how much sodium is in the burrito. 2,860 milligrams. But it beats the Olive Garden entree. But look how much is in the pasta. 2,500 milligrams of sodium. Way too much. And the American Heart Association has, listed what are called the salty six, things we can easily tell people to try to cut down on or avoid. Bread and rolls, pizza, sandwiches, cold cuts, and cured meats are a big canned soup, especially canned soup, and have a lot of sodium. And here are burritos and tacos. Now, what are some strategies for sodium reduction? Read food labels. Encourage people to read food labels and buy low sodium versions of foods. Stick to fresh foods as opposed to canned foods, and cook without salt. Now, aldosterone has a role in hypertension in that it causes sodium retention and volume expansion, an upregulation of angiotensin II receptors, and a potentiation of the pressor response to angiotensin II, leading to, as I said, volume expansion and hypertension. One clue to hyperaldosteronism is hypokalemia, either a low normal or a low potassium, even despite a potassium sparing agent or potassium supplements. But people can have hyperaldosteronism with normal potassium, so that's not exclusive. This is just to point out that hypertension early in life can indeed lead to adverse events. This is a paper from JAMA Pediatrics, showing that 25,000 children versus matched controls with a mean age of 11 who had hypertension went on to have a 2.3 times hazard ratio of major adverse cardiac events in a 28-year follow-up. And if the mean age was 11 when they started, 28 years later makes them under 40 years old, and they're already having adverse events. So the point is, pay attention to hypertension, even in younger people and in children, and treat accordingly. Now, there are some what I call early markers of hypertensive cardiovascular disease, previously called end organ damage. So for blood pressure, there is the exaggerated blood pressure response to exercise. So if you do an exercise stress test and systolic blood pressure rises to over 210 in men and 190 in women, that's an exaggerated blood pressure response. Even if their resting blood pressure is normal, that person should be followed, I think, more closely, because that's an early and abnormal sign of hypertensive cardiovascular disease. Another thing is the loss of the nocturnal dip. Dippers and non-dippers is sort of it's an English term. So that there is a circadian variation in hemodynamics and catecholamine levels. Those levels and blood pressure are all higher during the day and fall at night with a low, something like 4 in the morning. And then This is an exaggerated dip, but this is a non-dipper. See, the blood pressure doesn't fall at night. This would be especially true of people with sleep apnea, who never really get a good night's sleep unless they use CPAP. We're going to talk about that. Cardiac markers of hypertensive cardiovascular disease include left ventricular hypertrophy, either on ECG or on echo, diastolic dysfunction, and the presence of coronary artery calcium, which of course is a sign of coronary artery disease. The only way you can have calcium in your coronary arteries is if you have arteriosclerotic coronary artery disease. Vascular marker includes increased carotid intimomedial thickness, and then there are renal markers and retinal artery changes. Now, turning to treatment, there are a number of non-pharmacologic interventions for the prevention and treatment of hypertension, and we should all be talking to our patients about these. Weight loss, for example, the goal is ideal body weight. For every kilogram of weight reduction, there's about a millimeter of blood pressure reduction. The DASH dietary pattern, or the Mediterranean dietary pattern, which includes fruits, vegetables, and is relatively low in fat. Reduced dietary sodium, optimally under 1,500 milligrams a day, but 2,000 would be a reasonable goal for most people to try to achieve. An increase in dietary potassium, increase physical activity, exercise and move. Moderate your alcohol consumption. If you ingest more than 2 drinks a day, it's harder to control blood pressure. You need to emphasize that to people. And then it's been shown that people with sleep apnea who wear their CPAPs for more than 4 hours a night had a significant blood pressure reduction, you see, especially at night. This is some information on weight loss. Two recent studies. One, a 5-year follow-up of bariatric surgery. And when people who were treated with bariatric surgery as opposed to medical therapy, the people who were treated with bariatric surgery lost an average of 55 pounds. And at the end of 5 years, almost half of them were not on any blood pressure medicine anymore. This compares with only 2.4% of people who were treated with medical therapy. This is one of the GLP-1 so a 36-week study showing that blood pressure fell with the drug that induced weight loss. So the mechanism was weight loss, it's not a blood pressure effect. Here are the 2018 physical activity guidelines that will remind you to move more and sit less, that everything counts. Any amount of physical activity has health benefits. The goal is 150 minutes per week of at least moderate physical activity. That would be 30 minutes 5 days a week. Physical activity helps prevent 8 types of cancer, reduces the risk of dementia, reduces all-cause mortality, heart disease, stroke, high blood pressure, type 2 diabetes, and depression, and improves bone health, physical function, and quality of life. For older adults, physical activity also lowers the risk of falls and injuries from falls. So you don't fall more, you fall less if you try to remain active. And any exercise training mode improves blood pressure. So this is aerobic exercise. This is interval training. This is isometric exercise. This is combined training. And the point is they all work. The best program, in my opinion, is a combined program of aerobic and dynamic resistance training. So I have been writing what I call the exercise prescription. Okay, so here's the exercise prescription. And it has 3 parts. Frequency, at least 3 times a week, but more is better. Intensity, at least moderately hard or brisk. Yeah, brisk but comfortable. You really have to know you're exercising. Walking in and out of stores in the mall doesn't count. Well, any walking counts, but it's not in my exercise prescription. And the duration is 30 to 45 minutes with warm up and cool down periods. So back to the 2017 hypertension guideline. These are treatment thresholds for adults with high blood pressure. And the treatment thresholds depend on risk. The idea being to apply more intensive treatment to people at higher risk than at lower risk. So the 10-year risk under 10% is calculated from the AHA-ACC risk calculator. There's a new risk calculator called Prevent that's now available online, but not as an app for your phone yet. But for people who have a lower risk, if their blood pressure is elevated, emphasize heart healthy lifestyle. Actually, for higher risk, if their blood pressure is between 120 and 129, again, emphasize heart healthy lifestyle. For lower risk patients who have blood pressures between 130 and 140, push on the lifestyle modification and begin drug therapy at 140/90. If the risk is higher, however, a 10-year risk over 10%, diabetes, chronic kidney disease, start pharmacologic treatment at 130/80. The treatment target is 130/80. Now, since 2017, a number of reports have produced major findings. Out of office blood pressure readings are recommended, both to detect white coat hypertension and mask hypertension. Mask hypertension is normal blood pressure in the office and high blood pressure out of the office. It's the most practical method to document blood pressure for titration. Anybody with difficult to control hypertension should be screened for primary aldosteronism. Again, young adults, I've already mentioned, do not delay treatment. Lifestyle modification alone improves blood pressure, but it also improves the effectiveness of pharmacologic therapy. Intensive blood pressure control is not associated with serious side effects. For older adults with hypertension, there's some evidence that blood pressure treatment may at least partially arrest cognitive decline. And what's suggested, and we're going to talk about this again, is a multi-level, multi-component implement strategy, team-based care, utilizing all of the personnel and tools, pardon me, that you have at your disposal. Now, which medicine to choose? The answer is, in many respects, it doesn't matter. That is to say, the major determinant of cardiovascular risk reduction is the amount of blood pressure reduction and the blood pressure achieved, not the choice of drug. So this over here is a recently published 23-year follow-up from the ALLHAT trial. The ALLHAT trial was one of the trials that informed the JNC7. So it was reported back in the early 2000s, 2002 or 3, I've forgotten which. But the long-term follow-up shows that there's no difference in long-term mortality whether you took chlorthalidone, amlodipine, or lisinopril. There you go. So there are some exceptions. Now, there are some exceptions. One exception is that in the accomplished trial, benazepril and amlodipine combination was better at reducing adverse consequences than benazepril and a diuretic. And then people with comorbid conditions may have non-blood pressure indications for medications. If you have heart failure or diabetes, an indication for an ACE or an ARB. If you have AFib, AV nodal blocking drugs may be indicated. And if you have heart failure with a preserved ejection fraction, spironolactone may be indicated. Each class of antihypertensive agent gives a good response, a good blood pressure response in something like 30 to 50% of patients. There's a wide variability, and the response to the second drug will be in the similar ballpark. So the approach is to start with proper blood pressure measurement. If the blood pressure is elevated, initiate ACE and ACE. If the blood pressure is over 20/10, so that would be over 140 over 90. Initiate 2 drugs at small doses. If blood pressure is not that high, is the patient spilling protein in his urine? If not, either an ACE or a CCB would be your starting drugs. If the patient is spilling protein, initiate an ACE or an ARB. The blood pressure remains uncontrolled, combine. If it remains still uncontrolled, add a thiazide diuretic. You notice that beta blockers aren't in here. They are not a first-line blood pressure drug anymore. Reassess after 2 to 4 weeks, right? So don't let it go 3 to 6 months. Have the patient back in 2 to 4 weeks. If you can't see the patient, have your medical assistant take their blood pressure, get home blood pressures, and have them, text them or fax them or bring in the sheet so you can adjust doses of blood pressure medicines accordingly. Avoid therapeutic inertia, right? Therapeutic inertia is where a patient comes in, blood pressure is too high, and nothing changes. The concept that combination therapy is better than the maximum dose of one medication is something also to consider. The most common causes of a lack of response are medication non-adherence, a white coat effect, and improper blood pressure measurement. This just points out that indapamide and chlorthalidone are lower blood pressure better than hydrochlorothiazide. It was the initial reports were that there was cardiovascular protection, but not in subsequent reports. This comes from the American Diabetes Association's diabetes care. In January, they published standards of diabetic care every January. This is from the hypertension section of that report. And the ADA recommends treatment if the initial blood pressure is greater than 130 over 80 and less than 150 over 90. Start one agent. Lifestyle management, same, right? If the initial blood pressure is greater than 150 over 90, start two agents. With no albuminuria, you have a choice of drugs. With albuminuria, use an ACE or an ARB, and that would be the same, regardless of blood pressure, regardless of initial blood pressure. The treatment targets have really been changed. The 2017 ACC/AHA guidelines, as I've already stated, are that the blood pressure target should be less than 130 over 80 in higher risk patients. But the Diabetes Association in its most recent publication in January of this year recommends a blood pressure goal of 130 over 80 for all. Even the AAFP now recommends a blood pressure under 138. They used to recommend it for older people under 150, which I think is too high. Okay, and then of course, if the treatment is tolerated and the target is achieved, continue treatment. If you don't meet target or there are adverse effects, change medicines or add and etc. Now, there are a number of secondary drivers of hypertension, which include chronic coronary disease, which include medications like NSAIDs. NSAIDs are really the worst in the sense that people take them and you have no idea because they just take them at home. If somebody takes two ibuprofen, because they have a pain somewhere one day, that's not going to do it. But if they're taking ibuprofen every day, that is going to be a problem. ADHD meds, other stimulants are other culprits. Sleep apnea is a culprit, at least in part because of the lack of nocturnal dipping. And primary hyperaldosteronism. So, when and where to look for that: severe or resistant hypertension, hypokalemia, sleep apnea, unexplained atrial fibrillation. Now, turning to resistant hypertension. Resistant hypertension is a continued hypertension despite three or more drugs. But before you make the diagnosis of resistant hypertension, exclude the following conditions: secondary hypertension, pseudo-resistance, apparent hypertension due to lack of medication adherence or poor blood pressure measurement technique, that lack of adherence. Do you have a patient with resistant hypertension or a resistant patient with hypertension? I've seen both, as I'm sure you have as well. Mask hypertension is a low clinic blood pressure and a high out of office blood pressure. White coat hypertension is the opposite. Their home blood pressures are normal, and the clinic blood pressures are high. So exclude those before you diagnose resistant hypertension. And then ensure a low sodium diet, maximize lifestyle intervention, including sleep. Right, sleep is the latest addition to the Heart Association's essential 8 healthy behaviors. And then optimize your three drug regimen. So make sure they're taking drugs in 3 different classes. The diuretic type must be appropriate for kidney function. If the blood pressure is still not at target, substitute chlorthalidone or indapamide for hydrochlorothiazide. If the blood pressure still is not at target, add spironolactone. Eplerenone is a second mineral or corticoid receptor antagonist. It's similar to spironolactone, except that it does not have the gynecomastia and hirsutism side effects. If the blood pressure is still not at target, and the blood and the heart rate is high, then add a beta blocker. Step 5 would be to add hydralazine. Step 6 might be to add or substitute minoxidil. So here is a situation that I think a lot of us face. Here's a 53-year-old asymptomatic African-American man. This was actually an e-consult sent to me by a clinic provider in Florida. The man was from the Bahamas, had come to Florida with a history of hypertension and type 2 diabetes. So she saw him for a new patient visit. His history was that he had hypertension treated with valsartan, hydrochlorothiazide, and nifedipine, but he hadn't taken his medicine for the last 2 months since he'd been in the United States. He had diabetes with an A1C of 10.2, which he self-treated with diet and weight loss. So let me look at the won't let me look at the chat. I'm sorry.
Here, I have the chat up.
Yeah.
Order ECG, labs and echo, restart meds, send to the ER, EKG labs into the ER.
So they're answering the questions that are on this slide.
Yes.
Okay, right. So the blood pressure. Okay, they're half a step ahead of me. Okay, so right. On exam, this person had a blood pressure of 226 over 135, but his exam was otherwise entirely normal. And so, what would you do? Is this a hypertensive emergency? Order an ECG and basic labs, order an echo looking for LVH, order a nuclear stress test, take 2 Valium and call me in the morning. That's I don't know how many of you know that old joke, that old doctor joke. take 2 aspirin and call me in the morning, when somebody would call late at night for some condition that was clearly not serious, but the patient was worried. Restart meds and follow up in 2 weeks. So the question is which. So what are some of the answers, Jennifer?
Some of the answers are order ECG, labs, and echo, restart meds, send to the ER, EKG labs into the ER.
Okay. Well, let me tell you what a true hypertensive emergency really is. It's a blood pressure of 180 over 110 with one or more of the underline with one or more of the following: hypertensive encephalopathy, an intracerebral hemorrhage, a stroke, an acute MI, left ventricular failure, unstable angina, dissecting aneurysm, acute renal failure, or eclampsia, right? That is to say, it used to be called hypertensive urgency, but that's probably not an accurate term. This is really uncontrolled blood pressure, but not an emergency. So no, I wouldn't send him to the emergency room. He should have an ECG and basic labs. Well, anyway. The ECG, at least in part, is to make sure that there is no cause for an emergency. An echo should be done in somebody whose blood pressure is that high, looking for left ventricular hypertrophy. He doesn't need a stress test because he doesn't have chest pain, or doesn't have any chest symptoms. So what the practitioner did, and with which I agreed, was to restart his meds and follow up in 2 weeks, which is the answer in that situation. So make sure that that none of these things are taking place. But if none of them are, and his exam is normal, in that case, restart his meds and and make sure you follow up. So my approach to blood pressure goals is don't let controversies about the goals, right? I mean, there was, the Heart Association said one thing, and the Europeans said another thing, and the AAFP said a third thing. Don't let whatever their controversy over the goals are, is keep you from treating it in the first place. If the blood pressure is too high, treat it. Don't let the patient use the excuse that, quote, I've always had high blood pressure. Well, yeah, maybe you did, but you shouldn't. So, don't let that keep you from lowering the blood pressure. Use a stepwise approach. Aim for a systolic pressure of under 140. If you can accomplish that without side effects, aim for under 130. It may take some convincing of people to take that extra step, because they'll feel that their blood pressure is better. And why isn't that good enough? The answer to that is that, for each blood pressure reduction, there's a reduction in the risk of adverse events. Smaller doses of 2 drugs may be more effective than pushing one to its maximum. And don't let therapeutic inertia keep you from changing or up-titrating medicines. And we all need to improve adherence. So educate and counsel patients using what are called motivational interviewing techniques. Try to simplify regimens. Fix those combinations where possible. Encourage the home blood pressure recordings. I've had patients do you take your blood pressure at home? Yes. Did you write it down? No. What was it? Well, yesterday it was, but what's it been for the last 3 months? They have no memory. Or they write it down carefully, and where are your blood pressure readings? They're in the car. They're at home. I forgot to bring them in. Well, please bring them in. Um, my poster boy of home blood pressure recordings is the guy that worked for Oracle Computer, who would bring in an Excel spreadsheet with his blood pressure taken every day with the averages and the means. So it was easy to see what the calculations and what the average blood pressures were. Intensified treatment in the setting of suboptimal adherence. Use 90-day refills instead of 30-day refills. You utilize all of the all of the parts of the team that are available to help in trying to reduce people's blood pressure. Our clinic had a blood pressure program because we weren't meeting some of the HEDIS guidelines. And the program consisted of having the medical assistants who had treated the patient. Number one, repeat the blood pressure during the visit. Number two, call the patient at home and find out what their home blood pressures were. Number three, encourage more frequent contact with the heart care team, or use telehealth. During that pandemic, when I was only doing remote visits, it was perfectly adequate for people who took their blood pressure at home. They would tell me what it was. I could tell them what to do, how to alter the regimen, if necessary. This was a recent talk I saw from Roger Blumenthal, who used to be at Beth Israel way back when, and is now runs the the prevention center at Johns Hopkins Hospital. And he said, right, for blood pressure, right, 120 is the new 140. Lifestyle modifications first. For high-risk patients, add meds at 130/80. For low-risk patients, add meds at 140/90. Okay. And then we have one more prevention a bit of advice. To prevent a heart attack, take one aspirin every day. Take it out for a run, then take it to the gym, then take it for a bike ride. Thank you very much, everybody. And I'll be glad to answer more questions if there are any.
Okay, we do have a question. Are the alpha blockers meds you use at any point?
Like doxazosin? Yeah, about third or fourth, or for people who don't tolerate some of the other meds.
And how do you determine LVH from HTN versus endurance athlete status?
The subject of another talk. What you're referring to, a condition called, quote, the athletic heart. Over time, athletes who train intensively do develop LVH, but it's a dynamic LVH, as opposed to LVH due to hypertension. And one of the differences has to do with diastolic function. So LVH from hypertension will have diastolic dysfunction. The pressure inside the ventricle at any given volume will be higher than normal, and the ventricle will relax normal. The ventricle will not relax normally due to hypertensive LVH, as opposed to the endurance athlete whose diastolic function improves, so it relaxes better than normal during exercise.
I don't see any other questions yet. Another reminder about the CME survey. It'll appear in a tab when you close out of this webinar. We really appreciate you taking the few minutes to complete this. Not only does this give you CME credit, but also helps us to plan the best session for you. We share the feedback anonymously with the speakers, and they greatly appreciate your thoughts. So please be sure to fill out the CME survey.